Hi, this is Ginny Lobel with Defined Health, and we welcome you to today's Defined Health Insight Series webinar, New Frontiers in COPD, What's Next on the Treatment Horizon. Today's webinar will feature Aruni Don, Senior Consultant at Defined Health, and two panelists, Dr. Robert Vender, Professor of Medicine in Pulmonary Allergy and Critical Care Medicine at Penn State Milton S. Hershey Medical Center, and Dr. Irfan Rahman, Professor of Environmental Medicine, Pulmonary, and Public Health Sciences at the University of Rochester Medical Center. Before we get started, I'd like to mention that the Defined Health team will be participating in the following events next month. The Life Sciences Summit will be held November 1st and 2nd in New York City, where we'll be moderating panels focused on immuno-oncology, cardiovascular, CNS, and predicting the impact of today's bioinnovation. For more information, Google Life Sciences Summit 2017. We will also be at BioEurope in Berlin, November 6th and 8th, 6th through 8th rather, where we'll be moderating an I/O panel and meeting with companies in the partnering sessions. To learn more about Defined Health and our early strategic commercial development services, give us a call, send us an email, or visit our website at definedhealth.com. We hope to have time to field questions in the closing minutes of this session. Please send your questions in as you think of them, and if we don't get to them in today's allotted time, we'll follow up with you directly in the next day or so. We anticipate that slides and an audio-visual edition of this webinar will be posted on the Defined Health website within the next several days. So thank you for your attention. Please enjoy this session. I'm going to turn this over to Aruni, who will introduce herself as well as the panelists. Thank you.
Thank you, Ginny. My name is Aruni Arachike Don, and I'm a senior consultant at Defined Health. Since joining the company about 4 years ago, I have assisted clients with projects in multiple therapeutic areas. I now lead the respiratory practice at Defined Health. In addition to that, as part of a new initiative, I am also working with a team of individuals to expand and grow our current business in market access, reimbursement, and payer research. The focus of today's webinar is New Frontiers in COPD, What's Next on the Treatment Horizon. I will start with a brief overview of COPD that should take no more than 10 to 15 minutes. Joining me today are our two expert panelists, Drs. Robert Vender and Irfan Rahman. Following my brief presentation on COPD, the panelists will introduce themselves, and then we will spend most of our time having an in-depth discussion on key topics relevant for COPD. We hope to have approximately 5 to 10 minutes at the end of our conversation for questions from the audience. COPD is a complex chronic lung disease that occurs in a heterogeneous patient population characterized by airway obstruction, shortness of breath, cough, phlegm, and chronic persistent inflammation of lung tissue. COPD is a major global burden, and it is expected to become even a greater burden over the next decade. The World Health Organization estimates that COPD will become the third leading cause of death by 2030. According to data from the World Health Organization, there are an estimated 65 million people diagnosed with COPD worldwide, which includes approximately 15 million adults in the US. While there are geographic variations in the prevalence of COPD, the trend across the US and EU suggests 20 to 40% growth rate in the prevalence over 2 decades from 2013 through 2033. COPD is also on the rise in developing nations like China and India, caused by increase in smoking rates, but also due to environmental pollution such as biomass fuel burning, road traffic air pollution, and industry smog. Not surprisingly, a prevalent and chronic disease like COPD has significant impact on our health system. And this is a disease area that is going to get a lot more attention from payers in the coming years as we try to understand better ways to manage the overall healthcare spending in the U.S. When we look closer at the overall healthcare expenditure for COPD in the U.S., it is billions of dollars spent, and most of it is due to hospitalizations for COPD exacerbations. While the overall cost of treatment is a fraction of that spent in oncology, given that COPD is a chronic disease and the prevalence of the disease is growing worldwide, I expect the cost to continue to rise over the next several decades. There are pharma companies exploring avenues to monitor patients and develop biomarker strategies, diagnostic tests for early detection and treatment of impending exacerbations, and for prevention of ER visits and hospitalizations. This is another area of interest that appears to be growing for COPD that will certainly improve outcomes for patients and reduce the overall cost burden. However, the question is whether that's enough. We all know that smoking is the #1 cause of COPD. However, I would like to dispel the notion that smoking cessation alone is sufficient to address this global crisis. We know that smokers are 12 to 13 times more likely to die from COPD. Not only does smoking cause lung damage, but it also causes many other diseases and impacts the patient's overall health and quality of life. Clearly, smoking cessation would lead to a drastic reduction in the number of COPD cases, but not all those who smoke develop COPD. On the other hand, the data suggests that approximately a quarter of individuals in the U.S. diagnosed with COPD have never smoked. Studies show the presence of persistent, low-grade pulmonary and systemic inflammation in COPD patients, suggesting that there's a lot more going on systemically in COPD patients than the assumption that COPD is purely a local lung disease caused by smoking. There is a lot of interest in understanding the interaction between genes and the environment and how that contributes to the pathogenesis of COPD. This is a very active area of research, and we are starting to see some of the early results of genome-wide association studies and other sequencing studies. We will delve into the early science and the details of these studies during our Q&A session with our expert panelists, but I just want to highlight here that our panelist, Dr. Rahman, has spent nearly 2 decades studying molecular and cellular mechanisms involved in the pathogenesis of COPD, and I'm looking forward to this very exciting conversation. There's also a lot of interest in being able to predict response to COPD therapies and optimize treatment by better characterizing patient subgroups. We'll talk with Dr. Vender about the outcomes of several large observational studies designed to stratify and study patient subsets and what that means for him as a physician treating COPD patients. In addition, we'll touch on how biomarker strategies and better characterization of phenotypes and patient subtypes will impact the design of future clinical trials in COPD, and highlight opportunities to overcome some of the past hurdles for drug development in COPD. COPD is often referred to as a chronic lung disease, but I think it's important to note that COPD is really a systemic disease analogous to many other end-stage diseases. Treatment of COPD is further complicated by the fact that many patients have comorbidities, including cardiovascular disease and PAD. It's the underlying inflammation, narrowing of blood vessels, and fibrosis that seems to be the commonality among all these conditions. Moreover, studies show that COPD patients with persistent systemic inflammation have a higher mortality and exacerbation rate than patients without inflammation. In some ways, COPD is also analogous to Alzheimer's disease, yet another end-stage disease with underlying inflammation in the brain playing an important role in the disease pathophysiology, and current treatment options are all symptomatic-driven. There's active research focused on developing disease-modifying treatments to stop or delay the disease progression in Alzheimer's. So in many ways, there are important and common lessons to be learned and challenges for drug development. During our Q&A session, we'll talk more about the role of inflammation and the potential for developing systemic-directed anti-inflammatory and other targeted therapies for COPD. I'm going to spend the next few minutes covering current treatments, unmet needs, patient segmentation based on our current understanding of COPD, and how that is evolving with new guidelines. I will then end my presentation with the focus of this webinar, which is New Frontiers in COPD, What's Next on the Treatment Horizon. For decades, COPD patients have been classified into mild, moderate, severe, or very severe based on disease severity and FE1 scores, and grouped into GOLD 1 through 4, respectively. The recommended treatment for each patient segment, as noted on this slide, include inhaled corticosteroids, long-acting beta agonists, and long-acting muscarinic receptor antagonists, either as single agents or in combination, depending on the disease severity. Because of the limitations of assessing patients simply based on disease severity and FEV1 scores, the GOLD guidelines have recently been updated to a composite clinically based classification of patients designated as GOLD A, B, C, or D. Along with these categories, you can see treatment recommendations for each patient group, but as Dr. Vendor will point out, no two patients are alike, and treatment must be tailored to individual needs. The most significant changes of the new classification system are assessment of COPD refined to separate the spirometric assessment from symptom evaluation. ABCD groups are now proposed to be derived exclusively from patient symptoms and their history of exacerbations. For each of the groups A through D, escalation strategies for pharmacological treatments are proposed. The concept of de-escalation of therapy is introduced in the treatment assessment scheme. Non-pharmacological therapies are comprehensively presented. And finally, the importance of comorbid conditions in managing COPD is introduced. Despite the progress and these important steps forward to better classify and manage COPD patients, it seems that the change in COPD designations from severity-based to composite clinically based has had little impact on predicting outcomes like mortality. Later during the Q&A session, we'll talk details with Dr. Vendor about what impact the new classification system has had or not had for COPD. I think it's also important to point out that pharmacological management of COPD has been without any major breakthrough therapies for the past 2 to 3 decades. The inhalation-based drugs currently approved for treatment of COPD are all focused on addressing the symptoms. Basically, they relieve symptoms, and some of the drugs may decrease exacerbations. Highlighted in the table on this slide are the COPD drugs with exacerbation data, but none of the current COPD drugs reverse the underlying scarring of the lungs and airways. The reference here to Monty Python and the Holy Grail is not meant to highlight the British humor, but to make the point that there is a high unmet need for novel drug therapies to modify the disease course, slow or stop the progression of COPD, and ultimately reduce mortality. The quest for such therapies and the road ahead may be challenging, but still one that must be pursued, which may lead to some important new treatment options for COPD. When we took a closer look at the COPD pipeline, which is pretty robust, majority of the late-stage products in development for COPD are ICS, LABA, LAMA follow-on drugs in new delivery systems or combinations of these classes. What's interesting is that there is a growing list of novel therapies with new mechanisms, mostly in early stages of clinical development. Although it is too early to tell whether any of these therapies has the potential to modify the disease and or reduce mortality in COPD, these drugs target key aspects involved in COPD pathophysiology like inflammation and oxidative stress. We'll talk with our panelists to get their take on what's most interesting and what they are most excited about. Another important point is that some of these agents in development are small molecule oral agents or biologics being developed as a systemic treatment. I think there's so much more that still needs to be unraveled in the coming years. COPD is further behind compared to our current understanding of the disease biology and the pathophysiology of asthma, but it does look like we are going to be looking at COPD in a completely new way as our rudimentary understanding of COPD evolves in the coming years. I'm excited to see an explosion of new, targeted, and personalized treatments entering the COPD market over the next few years. I'd like to end my presentation by saying that in general, respiratory has not been a space with a lot of deal activity in comparison to some of the more active areas such as oncology. Nonetheless, in recent past, a few biopharma companies have been very successful in being acquired. Although there is limited deal activity in COPD, given the global impact of this disease and what we can expect to see over the next decade, pharma companies will need to start paying close attention to this category and invest in the development of novel targeted therapies for COPD. It is time for new wave of COPD drugs to advance into late stages. The focus really needs to start shifting away from treating symptoms locally in the lungs to addressing the disease as what it truly is, a complex systemic condition with significant impact on patients' quality of life and on the healthcare system. Historic lack of pharmacological innovation in the space over the last several decades, other than the development of new delivery technologies and combination of existing agents, should not deter pharma companies from development of innovative new therapies for COPD, focusing on novel mechanisms and drug targets. Indeed, the risk of development is high, but the endeavor could turn out to be very rewarding for those companies that pursue the COPD market. With that, let's now turn to the discussion with our panelists. But before we get started with the Q&A session, I would like to take a minute to thank Ed Saltzman for his guidance and Akash Kadakam for support in preparing this webinar. Thank you both. Dr. Robert Wender and Dr. Irfan Rahman, why don't we take a few minutes here to introduce yourselves? Dr. Wender, let's start with you.
Yes, thank you for the invitation to participate, and I certainly appreciate all the attendees who are participating also. My name is Robert Vender. I'm a board-certified adult pulmonary critical care physician practicing currently at the Penn State Milton Medical Center. Thank you.
Dr. Rahman?
Yeah, Dr. Irfan Rahman. I'm a professor at the University of Rochester Medical Center, upstate New York, in environmental medicine, pulmonary medicine, and in public health sciences. I've been involved in basic COPD research from the outset when actually the definition of COPD emerged, and this was with Dr. Bill McNee at the University of Edinburgh, Scotland. So we started working on patient with COPD, with smoking history, and then we continued working on cellular models and mouse models using various agents to induce COPD to understand the pathogenesis of COPD along with the therapeutic targets. So I'm a member of ATS, American Thoracic Society, and Society for Toxicology. Thank you.
Thank you. So we will spend the bulk of this discussion covering the early science and focusing on new frontiers, what's on the horizon for treatment of COPD. But before we get there, I'd like to start with a few general questions. Let's start with the recent updates. And Dr. Rahman, you talked about the definition. So the definition of COPD has evolved over the years. There's a new definition, the most recent update of the GOLD guidelines has a new definition. And the guidelines regarding the patient classification has also been updated. So let's talk about those. Dr. Wender, can you start with this? Can you tell us what the new definition is for COPD and how it is different from previous definitions? And also, does the GOLD guidelines definition differ from the ATS or the ERS definitions of COPD?
All the current definitions are certainly in concert and in agreement with what that definition is. And when we look at the definition of COPD, as you stated, it has evolved over the number of years, but that evolution has really paralleled two pathways. The first pathway is clearly our scientific knowledge and understanding of the disease, and the second pathway is taking the impact of the disease out of the hand of the physician and putting it in the hands of the patient and identifying what are the factors that impact the patient rather than the factors that impact the physician. So early definitions were based purely on physiology, pulmonary function testing. They were sort of physician-directed, and symptoms was predominantly dyspnea on exertion, and the pharmaceutical industry and drug development paralleled how the evolution of this definition. Subsequently, based upon the emphasis now upon the patient, not necessarily just primarily the physician, we realized the importance of acute exacerbations, and we realized that acute exacerbations are a distinct entity, almost a natural part of the history of certain patients with COPD, but it has a great impact in terms of the patient's overall health, morbidity, mortality, progression of lung disease, severity of obstructive physiological impairment, and as noted earlier, healthcare expenditures and cost. As we became aware of that particular entity, then drug development very appropriately started to look at outcomes in terms of reducing or preventing exacerbations of COPD, in addition to the prior drugs which are predominantly directed at improving dyspnea on exertion. Most recently, we've recognized the importance of comorbid factors in terms of the health impact on patients with COPD, again, getting out of the physician impact but the patient impact, and realizing these patients are associated with nutritional abnormalities, accelerated aging, advanced atherosclerosis, and the development of lung cancer, which then led to the recommendations to start screening patients for lung cancer to identify that as an early stage. But it seems like we stalled at this point. But the point is that the definition has evolved. We're all in agreement. And as we've shifted our paradigm to what impacts the patient, the focus on the patient, but also directed by the science, clearly our definition has evolved and will continue to evolve. Thank you.
Okay. And as a follow-on, does your approach to management of your patients then evolve with that definition? Are you now more focusing on those comorbidities and exacerbations?
Yes, your assessment and your awareness that is extremely accurate. Yes, it has clearly expanded how we look at these individuals in terms of their overall global health, not just simply focusing on their dyspnea on exertion. You are absolutely correct.
Dr. Ryman, what are your thoughts on the evolving definition of COPD, and what does that mean for someone like you who conducts basic research?
Yeah, so as Dr. Vender alluded, that is a very clear definition along with the line of the gold guideline as well as ATS and ERS and other specific regional societies globally. There are different guidelines based on different parameters of exposures and the progression in the patient population. So one more thing I would like to input along with Dr. Vender is the definition also emerged along with line of treatments. For example, we have mild, moderate, severe, and very severe COPD, and then the response to drugs also define the condition of the COPD, the nature of the progression of the COPD. And then there are a couple of other factors also emerge in the definition of COPD based on basic research as well as patient population. These include comorbidities and that associated with the muscle loss or neurological alterations or the cardiovascular mortality or morbidity. And then along with the same line, they are associated with lung cancer. And then depends on the exposure, like their condition of COPD, they are non-smoking COPD, and that has not been included in the guideline yet, but perhaps will be included. And there are countries where environmental pollution is high, there's a non-smoking, and that actually coincide with the another chronic airway disease, which is asthma. So there's a new definition is emerging, ACOS, which is asthma COPD overlapping syndrome, and that's defined the asthmatic, which has atopy with high serum IgE level and with eosinophil mediated the immune and inflammatory responses, and that's another condition being emerged. So that maybe another classification will come into place in COPD definition.
Yes, and I will touch on the asthma COPD overlap in a few minutes. But going back to the definition, now you mentioned earlier that you're using animal models of COPD. How does that changing definition impact what you use in the lab as far as trying to study these the COPD pathogenesis?
Sure. So we have different models of COPD we use in the lab, and basically we see the endpoint, which is mainly the alveolar wall destruction, that's the emphysema. Another phenotype of COPD, which is the emphysema, and then we can make the exacerbation models using the viral infection and bacterial infection. So basically there are only two key or distinct models we have in the lab, using mouse model, or some people use rabbit model or hamsters and some other models people have been using. So it's very similar to the COPD what we see in emphysema category. And then exacerbation model can see the airway inflammation, and distinctly mouse and animal are different. So hence some of those things which we see in human, we cannot see in mouse model. So these are the things in cellular model we use just to look the some cellular aspects, and patient with COPD, if they have cells, we have cells, then we can look certain models of COPD. So basically we have only two models here.
So far. And I'm going back to Dr. Vender. I wanted to ask you about, the definition of COPD. Now, we know that COPD is not a single disease, and you had mentioned this at one of our prior discussions. It rather consists of three distinct pathological processes. Can you elaborate on what those, that's specific to anatomic locations? Can you elaborate on that aspect?
I tend to look at the disease process, and this is limited to the disease process, not necessarily the clinical manifestations, as really three distinct entities of three distinct anatomic areas of the lung. The large airways that are associated with mucus secretion, where the scientific background in terms of mechanism appears to be much more genetic modification than necessarily the inflammatory mediators you see in other areas. Then you have the disease of the small airways. The disease of the small airways, which we define as a terminal bronchioles, less than 2 millimeters in internal diameter. That pathology and that inflammatory profile is what leads to the obstructive impairment that we associate with a chronic bronchitis. Again, a scientific and a basic science mechanism that's going to be different than what you're going to see in the large airways, and what you're also going to be seeing different from the last component anatomically of COPD, that's emphysema, which is alveolar destruction. So each of those, I think, represents a distinct target in terms of pharmacological manipulation, but we are learning that they are linked somewhat. For instance, the most recent development is that everybody will acknowledge that in emphysema, you have lung destruction, vanishing lung, you lose alveoli. But it's turning out that's the case also in the small airways, that it's not just mucus and inflammatory mediated narrowing, but there's a dropout and an actual elimination of the small airways destructively, almost analogous to the level of disease severity. So it really is three distinct anatomic, scientifically, and that then translate into different pathophysiology and symptoms in those anatomic areas.
And the potential to target those specifically, locations.
I will believe each one will have a specific target, yes.
Right. So on the other side, now I discussed in my presentation, the fact that we often refer to COPD as a chronic lung disease. However, it's more likely that it's a systemic condition. And the question is for Dr. Vender, should we continue to treat COPD locally with inhalation-based products, or should we start to look at the COPD as a systemic inflammatory disease and treat it as such with systemic-directed treatments? Or do we see going forward a combination of both being used?
There certainly is value in combination therapy, and I'm not going to minimize the achievements and the advancements we've seen in relation to inhalational medications in terms of treating this disease. So clearly, the inhalational route is extremely important. However, as you said, the avenue of using systemic therapy also to target some of the disease pathogenesis in COPD is also a very valuable a therapeutic approach. I think, as you alluded to earlier, this has been taken advantage of and exploited to remarkable efficacy in patients with asthma. It's also been taken and exploited to remarkable efficacy in patients with cystic fibrosis, which are lung disease also, with the utilization of the recent CFTR modulators. So I do think that from a therapeutic potential, both of them have extreme value. And the last caveat that I'll say in terms of trying to understand that is to make a point that it's not just the process that initiates the lung disease. It's not just the initiation of the smoking or the occupational exposure or the environmental exposure, but what are the factors that sustain the inflammation and sustain the injury? There's a very famous editorial that we all quote maybe now 20 years ago, where it was written in the editorial, and they stated, the lung inflammation burns on long after the cigarette goes out. So it does imply that there are significant systemic factors that are important in terms of sustaining the lung damage and the inflammation.
Uh-huh. And I think if you do treat it systemically, what are the advantages of going that route rather than what the current approaches, and what are the limitations of current inhalation approaches, basically?
Well, first, there is precedence for using oral agents. I mean, we do, the recent PDE4 inhibitor is an oral agent, and that's approved for treatment of severe exacerbations in COPD. So there is a proof of precedence, if that's the word to use. The advantages are that you can target areas that are sustaining the lung injury that may be derived from other parts of the lung, other parts of the body rather than the lung itself. Another example is prednisone when you need to use that. You're targeting other areas that are feeding the lung and contributing to the injury and the inflammation.
And you had mentioned that, there are biologics, systemic biologics developed and marketed for asthma that are being also developed for COPD as a follow-on. Any thoughts on that? We can come back to that, but does that make sense as a rationale approach?
Yes, I do think that once we advance to the knowledge level in terms of specific markers and specific biological targets as asthma, I do think we'll have the same ability to do that in COPD. The one other comment I make when I mentioned prednisone, obviously prednisone is not approved for a patient with COPD, except when they have acute exacerbations. But in terms of asthma, the efficacy is systemically, not just inhaled.
Mm-hmm. And with the oral medications for COPD, you talked about, is it roflumilast? What are the limitations of that drug or that approach?
In terms of the PDE4 inhibitor that's currently approved, is that what you mentioned?
Yes.
It's well tolerated. There are no significant limitations associated with that right now. And I think, like any drug, when you identify the various drug profile, the safety factors, the side effects, you're able to monitor them and avoid any high-level complications.
Okay.
So I don't think there should, at this point in time, just by looking at the route of administration, believe that there's going to be a limiting factor. It's going to be more dictated by the pharmacology of the specific compound that you're developing.
Okay. Dr. Rahman, do you have any thoughts on this? Can we see any lung spillover of inflammation?
Yeah, so I'll take you back with the earlier point where we see the larger airway destruction, where you see the larger airway inflammation, which is mucus hypersecretion, then airway, smaller airway component, which is more inflammatory responses. And then you have the alveolar space area, airspace enlargement, which is alveolar wall destruction. So in animal model, you can see all these changes. For example, we use a smoking model for a period of 6 months with mainstream tobacco smoke. You start seeing the airspace enlargement, and if you hit with viral, then virus infection, then you start seeing some neutrophilic inflammation. And FMLP model is another model where we see neutrophilic inflammation, which is mediated by the neutrophilic receptor. And then you have the other model which we use, elastase. Clearly we see the airspace enlargement. So in terms of spilling over inflammation, You can see all the models you see in systemic inflammation in patients with COPD. Certainly, it's been shown that there are inflammatory mediators, various chemokines, cytokines you can assess, and some of the biomarkers which we see perhaps will come in the next part of the discussion. So yes, there is a spillover of inflammation, which is therefore we call as a systemic disease, and therefore certain targeted therapies are based on systemic inflammation. So I agree with you. This is a systemic disease with inflammatory responses spillover. And there is another possibility of not only spillover, that there is a trigger of systemic inflammatory responses independent of lung component. So that's another thing is possible in spillover rather than a spillover of inflammation from the lung.
Okay, and continuing on that theme of inflammation, now we know that both asthma and COPD are inflammatory respiratory diseases, but would you say that the underlying inflammation in COPD is different from that in asthma? And what I mean by is, with a predominantly neutrophilic rather than an eosinophilic driven. And Dr. Rahman, would you like to speak to that?
Yes, so if you look the guidelines, COPD guidelines, GOLD guidelines, clearly there are neutrophilic and the mast cell and also eosinophilic for asthma, and then CD4 T lymphocytes versus CD8 in COPD. So these are the defined characteristics of COPD in terms of the systemic manifestation. And so yes, the systemic manifestation and associated changes are different, distinct in asthma and COPD.
Mm-hmm. And given that there are asthma biologics targeting eosinophils like anti-IL-5 and that are being developed for also COPD, does that make sense as a therapeutic strategy? And you can speak to that, and I'd like to get Dr. Vender's point on that as well.
Yes, it's possible, but depends on the patient phenotyping. And it's possible when there is asthma COPD overlapping syndrome, then it is possible. Otherwise, the COPD, if you look the mild, moderate, severe, very severe, the characterization of the disease based on GOLD guideline is different and is distinct. It's not given these anti-inflammatories at the earlier stages. And it comes in the severe, moderate to severe condition where anti-inflammatories are given along with inhaled corticosteroids. So currently, this is a debatable component where we can start the anti-inflammatories and things like similar systemic component earlier on. And, there is maybe Dr. Vender can highlight the earlier decline in lung function. Patients with COPD, they don't come to clinic. When there is a real drastic changes, physiological changes happen, then patients start coming to the clinic. So that's earlier diagnosis and earlier treatment might be beneficial to patients with COPD in terms of their progression. So that answers the lack of anti-inflammatories at earlier stages. And yes, systemic anti-inflammatories are given and are useful.
Dr. Vender, would you like to comment?
Yes, in relation to the biological targets in asthma and the extrapolation to COPD, I'll make a couple points. The first is, even in asthma, realize that the biological targets are different for different patients. And just like COPD patients have a variety of different endotypes, phenotypes, subgroups, whatever terminology you want to use, the same exists for asthma patients. So the biologicals are not one size fits all, but they're designed for certain types of patients that have certain markers and certain clinical presentations. And I do believe that that same breakdown will eventually apply to patients with COPD. We will provide that not as a global therapy, which is the current therapies we have. They're all global therapies, one size fits all, but to try to focus specifically to the subtypes in terms of the subtypes, how it impacts each individual patient's outcome. So even within asthma, the biologicals are not a general applicability to everybody. The one point I would make, though, is that when you look at the disease process, COPD and asthma, there is a marked distinction that you have to recognize. And that is, in treating asthma patients, the goal is to make them asymptomatic recover their lung function, and have them have normal physiology based upon pulmonary function tests. That is the goal of asthma therapy. That is not the goal in COPD therapy. The vast majority of patients with COPD present for evaluations already when they have a significant degree of irreversible lung disease that is going to progress. So the therapeutic goal is not to restore lung function or make them symptomatic, is try to slow the rate of lung deterioration and to try to minimize the symptoms, not eliminate the symptoms. So the treatment paradigm between asthma and COPD is markedly different, even acknowledging there may be some overlap potentially in the future in terms of markers. But the treatment from a clinical perspective, the treatment paradigm is so vastly different that it's important to emphasize that.
Yes, thank you for that, and I agree. That is a very important distinction. So continuing with the patient classification, we'll talk about the new GOLD guidelines. First of all, can you explain to us what each of those A, B, C, and D groups mean? And as a pulmonologist treating COPD, how has the treatment of this condition evolved based on this new classification system from the prior one?
Well, as we discussed earlier, as the definition of COPD evolved, it was purely based upon physiology and how we classified patients in terms of what we perceived as what was important, namely lung function. And that was based upon the severity index using the FEV1. As I said, the situation has changed now, or our focus has changed, to get away from lung physiology and look at other factors that really impact the patient's health directly. For instance, functional status. And I make the point that functional status is somewhat dictated by lung function, but not totally dictated by lung function. So there could be patients that have other comorbid diseases that have good lung function with very reduced functional status, as opposed to patients that have severe lung disease that don't have other comorbid disease that have reasonably preserved lung function, functionality. So we realized that the quantification based upon lung disease severity based upon FEV1% predicted didn't encompass the overall functional health of the patient and didn't encompass the other factors that affect their overall functional status, not just their lung status. So the evolution of the new definition is trying to take that into consideration. When you look at the various symptom scores that they recommend you use in terms of classifying with the new system, the ABCD system, yes, lung function impacts that. They don't actually measure it, but it does impact in terms of your functional status. So it will be somewhat reflective in there. But it also takes into consideration the amount of cough, the amount of sputum, and importantly, how many exacerbations you're having per year. So the advantage of going to the new classification is it still does encompass somewhat looking at lung disease severity by the FEV1 as it dictates to dyspnea on exertion, but it takes into fact also those other clinical symptomatology so that you're looking at the patient from an overall health status, not just focusing on the lung. Now, does that translate into any change in terms of how we practice in terms of treat these patients, in terms of pharmacologically or other therapies? Pharmacologically, no. I don't think it's impacted that. I think we still use the same agents that we've used, which you mentioned earlier, certainly have value, but they are limited in certain aspects of what they can do. But what it has helped us with, as we said earlier, recognizing all those other factors that affect the health of a COPD patient, so that now we are looking at other disease processes, we are looking at pulmonary rehabilitation, we are looking at nutritional support. So it has been extremely valuable in us recognizing, let's say, the non-pharmacological interventions in terms of these patients.
And continuing on that, I mean, does those categorizations or subgroups, can you identify a patients with rapid declining or those patients with increased risk for morbidity and mortality? Is it possible to identify based on that classification system?
I don't think that is as predictable yet as we hoped it would be. I do believe that when the classification first came out, that there was the expectation that it would be much more predictable than the severity of disease classification in terms of predicting mortality, not necessarily morbidity, but mortality. And part of that assumption was that if we're able to identify patients that are high risk for acute exacerbations and reduce those, that will then translate into mortality benefit. That may happen. It may still be discovered, but to date, it has not happened in terms of that connection just yet. So we're not able to translate these into any better predictability than what we've had previously.
Okay. And so, and you had mentioned in one of our initial meetings that we've been trying to characterize patient subpopulations based on phenotypes for decades, and going back to the days of pink puffer and blue bloater. So how is the new way of classification any different, or have we learned anything new today than 30 years ago?
The things that we've learned, as you said earlier, is that the spectrum in terms of the characteristics of each individual patient with COPD is quite broad. The heterogeneity of their clinical presentation, their morbidity, and their subsequent mortality is broad. And that one simple classification, be it 1, 2, 3, or 4, or be it A, B, C, D, has not been able to do that. That's why we're getting now into what you brought up, trying to classify patients in terms of their different clinical characteristics, which we put under subgroups or phenotypes. And we've now identified what appears to be, although it's not exactly validated yet, some groups of patients that appear to be dominated by other aspects of their health status than necessarily just simply their lung status. But the one that is most important, and where I think the greatest advance needs to come, and I do believe it will happen shortly, is in terms of identifying those patients that we call rapid decliners. It's a small number of the overall group of COPD patients, but it's those that certainly suffer the greatest in terms of their disease, both in terms of functional limitation and that are associated with increased mortality. So if we could identify some of those subtypes, especially the rapid decliners, both scientifically and clinically, yes, that would be extremely valuable, and from my perspective, would then be able to impact potentially with a greater probability than what we can do now, the mortality of this group of patients.
Okay. Now, I do want to also ask about, Dr. Rahman mentioned earlier the asthma COPD overlap population, and as of yet, there's not much information. Dr. Vender, can you describe, what your approach for management of these patients are, and is this a, what percent of patients have that overlap syndrome?
Yes, well, we talked about that there's a number of different breakdowns that we're identifying in terms of the various phenotypes. The patients dominated by their comorbid disease, which is mostly cardiovascular and atherosclerotic. Those dominated by the rapid decliners. Those dominated by body habitus and obesity hypoventilation syndrome. And in that group is now emerging the group that have the asthma COPD overlap syndrome. That is now becoming written quite a bit in the literature in terms of another distinct, let's say, clinical phenotype in patients with COPD. My perspective is it's still too early to make any judgments in terms of first validity, accuracy, epidemiology, and then subsequent therapy. So it is something that is emerging, it is something that is evolving, but from my own personal bias, and I'll use that word bias, I don't think the data is solid enough now to make any categorical statements about those facts I just mentioned.
Okay. Dr. Rahman, from your perspective, do you have any additional?
Yes, so as Dr. Venda pointed out about the rapid decliner versus slow decliners, there's one factor which has been in the literature, the number of exacerbations per year may predict the rapid decliner. So that's one aspect we can be used as a rapid versus non-rapid decliner. And then along the same line, the smoking cessation, rehab, and long-term oxygen therapy may be associated with those progression of the disease. So these are the only two additional points I can bring. And I agree, I concur with Dr. Brenda about the ACOS, which is asthma COPD overlapping syndrome. It's just emerged. We still would like to hear more about the clinical classification, definition, epidemiology, and subsequent therapies. So we know already that there are definition emerged in early 80s and 90s from Dutch, the definition of COPD versus British definition, an American definition, which encompasses all these phenotypes, asthma and smoking-related phenotypes. So this is not new. This is just based on clinical phenotypes we are seeing more and more in literature. So we would like to hear more in the future.
Okay. And I'd like to briefly touch on some of the data that has come out or from the large observational studies. Dr. Vender, I know you're familiar with these studies, the clinical trials in COPD. Based on what's been published and released, what new insights have we gained from studies like Eclipse, Pyromix, or COPD Gene?
In terms of the therapeutic clinical outcome trials, looking at the clinical outcomes of lung function, quality of life, prevention or reduction of the frequency of acute exacerbations or reducing the severity of acute exacerbations, we've pursued those only with the existent therapies. And I acknowledge the value of those existent therapies and the current emphasis upon triple therapy, a LAMA, LABA, and an ICS. But in truth, that has been practiced for an extended time now. It just is achieving its validity in the literature in terms of what's been practicing now for in the clinic for a long period of time. So I don't think the clinical outcome studies have really made any big impact from my perspective in the last 10 years. Clearly, the investigative studies, the scientific investigation studies trying to look at biomarkers, genetic linkage, various associated mutation analyses, probably have had a much greater impact in terms of advancing the knowledge of COPD, but none of them have gotten to the point to allow us to specifically identify one target or one specific area that's going to have current merit. So it depends upon how you look at the studies from the investigation scientific in terms of achieving data or trying to modify clinical outcomes.
Okay. And as a follow-on, this is a question from one of our audience members. Any thoughts on, the closed triple LABA, LAMA, ICS products, especially the results of the IMPACT study announced by GSK last month?
What will be the impact of that information?
Yeah.
That's good. Yes, I can. My perspective is that there's a different viewpoint in terms of how patients are treated with these agents based upon whether or not you're a pulmonary physician or a primary care physician. And I'm a primary care physician unless I'm a pulmonary physician. So I don't mean anything in terms of any negativity one way or the other. I am a primary care physician. I think the patients, pulmonary physicians, tend to see a higher level severity COPD patient where exacerbations, lung decline, hospitalization is much more dominating their clinical course. And because of that, I think we have been on board with triple therapy now for quite some time. I think the most recent studies, the impact they will have will be more in terms of the primary care physicians who are treating patients that maybe do not have the same high level severity of lung function or comorbidities in terms of them becoming aware of possibly initiating these therapies in an earlier stage.
Okay, got it. So we know, let's talk about biomarkers a little bit more detail. We know that we can use biomarkers for different purposes. For, example, early diagnosis with diagnostic tests and for predicting disease course and progression. It can be used for defining patient populations and to measure response to therapy. Dr. Rahman, would you like to briefly explain to your audience what are the various types of biomarkers relevant for COPD and what types of biomarkers have been identified thus far? And I'm really more interested in, given your research background, interested in some of the genetic biomarkers and COPD susceptibility and resistance genes to talk a little bit more about that.
Sure. The initial biomarker, which is clinical biomarker, which is a decline in lung function, is a predictor. But along with the other biomarkers, there are several other biomarkers being proposed and one can see in the literature that there are certain biomarkers, but they are not specific to either the biomarker of exposure of the environmental agents like tobacco smoke, or the biomarker of progression of the disease, or biomarkers of the therapies. Upon therapies, then one can predict whether this patient is going to get rapid decliner or slow decliner, or manifestation of the disease, or the progression of the disease. So the biomarkers is all originated from the spilling over of the lung inflammation into systemic component. And there are certain biomarkers one can see in exhale breath condensate, which is still emerging, certainly is non-reproducible, and is still having a debate on that, whether this can be used as a way of monitoring biomarkers along with the FeNO, which is nitric oxide, to differentiate between asthma and COPD. So along with the reversibility testing. So certain biomarker which came in initially, Dr. Torino's observation that desmosine is one of the potential biomarker, which is elastin fragmentation or the breakdown, especially in emphysema, which one can see in systemic circulation. So that is still hold its own way niche that one can use as a desmosine as a potential biomarker for COPD progression, especially the airway and airspace enlargement. So there are other potential biomarkers, cytokines such as IL-6, which is inflammatory mediators, and then comorbid situations, CRP, C-reactive protein, fibrinogen, one can see, and then certain other oxidant biomarker can be seen. So by eyesight, these biomarkers are not yet been shown to be determining factor for COPD alone per se, or with comorbidities, though the responses to therapies may be possible to look whether these biomarkers can go down. Regarding the exhale breath condensate that's come from the upper airways, one can see certain lipid mediators, oxidant biomarker, but has so much variability and so much non-reproducible yet to be tested as a key biomarker in that biological fluid progression of or therapeutic target efficacy of drugs in COPD.
So it sounds to me like it's still very early when it comes to biomarker strategies, and based on the current understanding, is there a specific biomarkers that you think will turn out to be more promising in for example, the cellular biomarkers or the genetic biomarkers?
Yeah, so cellular biomarker, I forgot to mention that neutrophilic, and eosinophilic and subtypes of T lymphocytes, they can potentially be used as a biomarker of predicting the disease and the classification of the disease. In terms of genetic modifications, not much is done in terms of classifying as biomarker, though certain nicotinic receptor like alpha-7, alpha-5, those receptors being classified as a polymorphism in nicotine addiction in patient with COPD, and then certain biomarker in terms of genetic came like serpin, and which is a proteases, and alpha-1 trypsin, which was the earlier diagnosis modification, and then polymorphism and inactivation of alpha-1 PI in very, very less number of patients can be seen. So genetic polymorphism or genetic testing of those yet to be put forward. Though lung cancer, we do have certain tests which we can see certain genes which are polymorphic or methylated, DNA methylation occurs. So yet to be emerged in COPD, whether we can see blood samples, we can look genetic polymorphism or DNA methylation and then profile the patient, yet to be determined. So there are studies being conducted, like for example, COPD gene scan that is still in progress, and other studies going on nationwide and internationally, and we should be hearing soon whether we can use gene as a polymorphism or gene mutation or gene different aspect of gene expression can be used as a way to determine, used as a biomarker for COPD.
Okay. Okay, so the next question, this is for both of you, and we can start with Dr. Vender. How do you expect the findings from, these the early biomarker studies to impact future drug development in COPD? And how should that knowledge from early science be incorporated into developing and optimizing future trials?
Okay, I did hear the question. Virtually all the pulmonary diseases that I deal with are in the process of identifying biomarkers in terms of giving them more accuracy in terms of defining a specific clinical scenario or situation. Realize that when we use the term exacerbation for a variety of disease, I know we're talking about COPD, it's a symptom-based definition. It's a change in pulmonary symptomatology, cough, sputum, or dyspnea on exertion that's a worse severity than the usual day-to-day variation. And using that as a diagnosis, as we discussed previously prior to this telephone conversation today, we overtreat a lot of acute exacerbations and we undertreat a lot of acute exacerbations because there's subjectivity in relation to that doesn't allow us to have that high level accuracy. So being able to identify a parameter that will assist in improving that accuracy will be extremely valuable in terms of being specific with therapy. So I do think that there is a tremendous avenue in terms of assisting the diagnostic and then the subsequent therapeutic direction in terms of that particular use biomarkers. Just as importantly, once we identify biomarkers, regardless of whether it's in stable disease, chronic disease, acute exacerbations, then we can work back and then implicate how these biomarkers really initiated in terms of contributing to disease, and then very appropriately target the disease at a very basic level. So I think the value of the biomarkers are not only going to be diagnostically, but being able to work back. Almost like when you find the gene, then you can identify the protein. You identify the biomarker, then you could track the source of that and how it really does lead to the pathogenesis of disease. And to me, that's going to be even more important.
Mm-hmm. Okay, Dr. Rahman, do you have any comments on how we can incorporate the information from the early science into clinical trials, and any recommendations or suggestions that you think from your perspective?
Yes, so certainly there are a lot of basic mechanisms are taking place, and a lot of different targets are emerging, and based on the clinical phenotypes of the disease progression. So for example, I can give you one example here. We have used in the past during acute exacerbation, though the patient with the stable COPD is taking N-acetylcysteine or N-acetylcysteine, which is an anti-mucolytic, antioxidant compound. And now the theory is that, okay, these compounds, they don't work because they only work as a mucolytic. And then the new concept emerged that ATP, which is inside the cell, come out and cause activation of purinergic receptors. And that can lead to mucus hypersecretion as well. So antitussive medication along the line can come and then can potentially be used with the LAMA and LABA and severe condition when there is exacerbation can be used inhaled steroid. So these are the emerging concepts, and similar thing goes to oxidative stress, NRF2 activation, and more recently that's been shown that aging component is associated with cellular senescence, and one can see in ex-smokers senescence is higher when the cells stop dividing and they release inflammatory mediators, and potentially you can see spillover of inflammation into systemic circulation. So anti-senescence therapy along with anti-neural, anticholinergic, antimuscarinic, or the antitussive agent can be combined along with even PDE4 inhibitors. So anti-senescence drug is another choice which will emerge into this scientific domain, clinical domain, and that can potentially be used for aging population when there is a rapid declining lung function, where ex-smoker even see more inflammation in their systemically. So there are things in progress with clinical phenotype. When these targets will emerge, these drugs will come, then potentially one can see there is a changes in the phenotype, and so there is a potential for therapy, potential for diagnosis and treatment.
Mm-hmm. And when we conducted an analysis of the pipeline, there were about nearly 70 new agents with novel mechanisms in early stages, and you touched on some of those just now. Any thoughts on, what specific mechanisms or drug targets would have are more likely to modify the disease course or prevent further lung damage in COPD? And I'll let you start with that, and maybe Dr. Vender can chime in as well.
Sure. So there are two important things been emerging, well, along with the line of anti-senescence drug. There is another component, epigenetic changes and stem cell therapy. These are the two very, very important novel findings happening in COPD in the line of treatment, in line of biomarkers. So, for example, we have DNA methylation. Now we can see epigenetic modification on histone modification, histone acetylation, methylation, and there are drug targets coming for cancer, EZH2, bladder cancer, colon cancer. So similar things can be seen, epigenetic modulators in COPD, and that potentially can be used when there is a lung cancer component overlapping. And then the stem cell therapies, certainly there is a very important finding that mesenchymal stem cells, they release certain mediators. So, and the progenitor cells, they have certain components. So those important contributors, the growth factors or the anti-inflammatories, can be used from those stem cells for delivering into the lung component where there is a real destruction or airway inflammation occurs. And again, then that brings to the delivery of the drugs, and that may be the other topic which we can discuss, how we can deliver these drugs. So yes, there are three major things along with what we have available: MMP inhibitor, antibiotics, then PDE4 inhibitors, chemokine antagonist, elastase inhibitor, toll-like receptor, and TSLP, anti-TSLP. We can potentially use epigenetics, anti-senescence, and stem cell therapy. So yes, the future is bright here.
Okay. Dr. Vender, any thoughts on what is a reasonable therapeutic strategy that's likely to transform the way that you would treat your patients?
Well, I will defer to Dr. Rahman on this topic. I really I don't have the in-depth scientific background or knowledge of these different compounds to really provide anything valuable for anybody in this situation. So I'll defer.
Sure. And so I think we have just a few minutes left. So I just wanted to ask, we focused on therapeutic strategies, but in addition to those therapeutic strategies, there are companies focusing on developing new diagnostics for early detection and preemptive treatment of the impending exacerbations. And there are even new technologies out there that monitor, for example, speech-based analysis of voice and breath to monitor COPD patients at home for early detection of an exacerbation. Any thoughts on how you, as a physician, would envision incorporating those approaches into your practice, and what kind of impact that would have on reducing the severe and repeat exacerbations, as well as the overall, impact on patient health?
Let's just talk about the disease per se, and then we can talk about exacerbations. But in terms of the disease per se, that information would be extremely valuable. And there's a couple of reasons to consider that. The first is that realize that in patients that have COPD, there is a long latency period before they perceive any symptoms of significance enough that they seek medical evaluation. And so most patients with COPD who present for evaluation and have the disease diagnosed already have moderate disease. And as I said, based upon FEV1 measurement, in contrast to asthma, this is not going to be recouped. So early identification of that group of patients and early recognition of that would be extremely important. The other factor to consider is realize that at most, 30% of patients that smoke get COPD. So there's something in that 30% compared to the 70% that make them predisposed, be it genetic, be it a combination of the environmental inhalational exposures. So if you're able to identify that high-risk group of patients who are going to get COPD if they continue to smoke and be in the environment, that would be extremely valuable in terms of providing that information in terms of lifestyle modification.
Okay, thank you. So I would like to wrap up with just a few comments. So COPD, we know it's a major global health problem. It costs the U.S. healthcare system billions of dollars annually for management of exacerbations and hospitalizations. And it's clear that the healthcare expenditure for COPD will continue to rise over the next decade. And so the question that remains is, as a society, are we ready to address this issue now or wait? We do need to be conscientious about the cost of care and payer trends in managing large therapeutic categories like COPD. And for companies developing drugs in this space, they also need to keep in mind that this market will largely become genericized as blockbuster products like Spiriva and Advair go off patent. So I think we're almost out of time. I know that we tried to address questions from the audience. Do either of you have any final comments before we end this presentation?
This is Bob Vender. I would just say that in relation to what you just commented on, the impact of this disease in terms of global health is expanding. The impact of this disease in terms of productive life that's lost or limited is expanding. The impact of this disease in terms of other comorbidities is expanding. So I think there's certainly a recognition and a precedence of the importance in looking and continue to drug development in this area and other therapies in this area also.
Okay, thank you. Dr. Rahman, do you have any final thoughts?
Yes, to look the clinical targets, the therapeutic targets, continue to work on therapeutic targets that can modify the progression of the disease, modifier of the disease, and based on triple therapies, and one can find a potential compound which can block oxidative stress, inflammation, senescence, and certainly modifying epigenetic changes at the same time, some stem cell modifications. So these are potential for the COPD based on different phenotypes, different clinical outcomes, and especially in smoking-related decline in lung function versus non-smoking decline in lung function. So there are potential for understanding targets and therapies.
Okay, thank you very much, Drs. Robert Vender and Irfan Rahman. This will end the webinar. Thank you for all those participating and listening in, and we will follow up with your questions via email. Thank you so much.